Thank you all so much for being here. Welcome to the CARE Crisis and Recovery Enhancement TA Center. We are thrilled to introduce you to Reverend Dr. Najuma Smith-Pollard. This is the first of a series of 4 learning collaborative sessions focusing on bridging communities between faith communities and behavioral health crisis care. It is very exciting to introduce you here to Reverend Dr. Najuma Smith-Pollard. We are so very fortunate that she is here with us from USC, University of Southern California. And today she's going to be talking about COVID-19 and natural disaster impacts on mental health crisis care needs and assets. And as I mentioned, this is the first of 4 sessions. So welcome to everybody who's here. I'm going to start off with the important disclaimer. We are so grateful to the Department of Healthcare Services for funding this project through the Mental Health Services Act. And those of us who are on the CARE team here, I'm joined by my colleagues, Ruth Santos, Ande Peña, Ayana McGee, and Stephen Jimenez. We work at CARS, the Center for Applied Research Solutions. We are so grateful for the funding and the institutional support from both of these agencies. What we're about to say here does not necessarily represent those agencies. So if you're new to the CARE TA Center, as I mentioned, we are funded through the Mental Health Services Act, MHSA, to provide training and technical assistance to the state of California regarding crisis continuum of care and justice diversion. We strive to work in tandem with county behavioral health departments and local community-based organizations and faith leaders and lay ministers to address these critical issues of crisis care and justice diversion, to help people recover from behavioral health crises in the community, to keep them out of institutions like jails and prisons, emergency rooms, and psychiatric hospitals, unless there's an absolute need to go there. Most times, a behavioral health crisis like suicide or overdose, or even intimate family violence can be handled in the community. We know that's where people have the best access to care and the best chances of recovery in an environment that is culturally responsive and least offensive and restrictive. Go to the next slide, please. We are thrilled to be a CARE TA Center based on a collaboration with several leaders in the worlds of crisis care and justice diversion. As you can see on this slide here, we work with Recovery International, National Association of Mental Illness, NAMI California chapter, C4 Innovations, Research and Action Center at Impact Justice, and Stanford Sierra Youth and Families. Next slide, please. We provide a variety of training and technical assistance, including virtual learning events like this session here today. If you were to go to our website, you would find that we have a robust library of evidence-based materials, from written documents to infographics and recorded sessions. We also provide what's called an asset map. This is an interactive map that you can go and find out what are the local crisis care and justice diversion services in your county and in the counties that are near you. So if you are working with somebody that is moving over to the next county, you can find out where to send them for referrals. Additionally, we have a newsletter, we have social media accounts. We invite you to stay connected with us through these communication platforms. And importantly, perhaps most importantly, we provide no cost training and technical assistance. So if you have questions following this session about how to implement any of the topics that we're talking about, please do let us know. And we'd be happy to meet with you and to match you up with a training and technical assistance specialist who has expertise in the area that you are asking about. So as I mentioned, today is the first of 4 learning collaborative meetings. These are 90-minute meetings, which are set up to bring together leaders in faith communities and leaders at the county behavioral health department level and community-based organizations. Today's session, as you know, is focusing on COVID-19 and natural disaster impacts of mental health crisis care needs and assets. We recognize at the CARE TA Center that oftentimes when people experience crisis, the first people that they reach out to are faith leaders and lay ministers. And in fact, what you all have been doing, those of you who are here as faith leaders and lay ministers, is you are critical first responders. We want to say thank you to you for doing that work. And we want to work in collaboration to share with you the crisis care resources that we have available in the behavioral health world, and to find how we can best collaborate with you, because we know that you're doing this work already from a faith perspective. So you see here that we have 3 learning objectives for today's event. At the end of this event, we are going to invite you to take a homework assignment, which is going to help in between this session and the next session, begin conversation locally, whether you're part of a faith community or a behavioral health department, to start thinking about how to build collaborations locally with the other group. So if you're part of a faith community, we're inviting you to connect with local behavioral health departments and vice versa. We'll go to the next slide, please. Our next session, which is on January 13th, is going to be looking at the crisis continuum of care resources, which are available to faith leaders and lay ministers, and faith-based behavioral health resources that are available to county behavioral health departments. So recognizing that both of our communities have been developing crisis resources to date and wanting to make sure that we can share them with each other. I am a social worker by profession. Before coming over to the Care TA Center, I know that when I was working with clients experiencing crises, if they come from a faith background, oftentimes it was that faith background, that faith that helped them to get through the moment. And so having these conversations, we know to be critical for that reason. But also many of us who are in behavioral health workforce enter the workforce because of our faith. We are drawn to this work for those reasons. We'll go to the next slide, please. On April 14th, we'll have our 3rd session, which is focusing on community-based suicide and overdose prevention, avoiding unnecessary hospitalization and incarceration. And our goal with the Care TA Center is to reduce institutionalization and to increase people's ability to recover from behavioral health crisis in the community. And critically important, the homework assignment for this session is going to be creating a SMART goal. And we can talk a little bit more about that later, but it's an implementation science approach to help us to achieve a goal and to track and measure its outcomes. And so that SMART goal will be specific to developing crisis care collaborations and resources between our faith communities and behavioral health departments. Next slide, please. And our final learning collaborative will be on June 16th. We are very grateful and looking forward to this conversation, so critical for a million reasons. Faith community and behavioral health department collaboration across funding. And this is going to be a very important conversation because we can talk about wanting to collaborate, but oftentimes the key ingredients such as funding and staffing really can make or break those beautiful visions that we might have together. So this is going to be an incredible opportunity to talk about getting down to the nuts and bolts, really, of how to make these collaborations work. Without further ado, I am so excited to finally introduce you to Reverend Dr. Najuma Smith-Pollard, who is going to be presenting today on COVID-19 and natural disaster impacts on mental health and crisis care needs and assets. If at any point you have questions regarding technology, please feel free to put a message in the chat box, and Mr. Stephen Jimenez will be responding. And without further ado, I would like to hand over the virtual mic to Reverend Dr. Najuma Smith-Pollard. Welcome.
Well, thank you so much, Heliana and the CARE team, and to all of you that are joining us here this morning, maybe this afternoon for some, if you're out of state, or tapping in from another part of the country. But again, thank you for joining us. Thank you for having me. I'm really excited to be leading this 4-part collaborative series. I do believe that each and every series will take us higher and deeper into the work that we do, but also allow each of us to serve more effectively the people that we've been called to serve in the communities we've been called to serve in. So thank you again to the CARE team and to all of you in attendance, those of you that are faith leaders and those of you that work in the behavioral health care field. So let's get into it with a little bit of introduction about who I am. For those that do not know me personally, I am the Assistant Director for Community and Public Engagement at the Center for Religion and Civic Culture at USC. But I'm also run the programming for the Cecil Murray Center for Community Engagement. And so that's the work that brings us together today. In addition, I'm a pastor. I pastor Word of Encouragement Community Church here in Los Angeles. I am native Los Angeles. LA is home, and I really have no intentions of leaving Los Angeles. I love LA. I'm committed to the people and the people of LA. And so I've always felt really called to my hometown to serve here. So I do it with great joy, but also just a lot of gratitude that God would use me in this way. I'm also a mom, so I have a couple kids. They're 12 and 7, Dorian and Zuri. And then I do have an angel child. His name is Daniel, and we'll be celebrating his heavenly birthday this coming month. And so this is a very special month for us for a number of different reasons. In addition, I'm an activist. I believe in a lot of the works. The picture you see here has me at a press conference with a bunch of other clergy and faith leaders here in Los Angeles. I do believe that my faith informs my feet. And so it is not just enough to preach the gospel, but the gospel must be lived. And so I make it intention to get out and be part of the work that's happening. Yes, in the pulpit, yes, in the corporate area, but also in the streets of here in Los Angeles and abroad. And again, I'm just grateful to be here with all of you today. So as we move forward in our presentation, we will be talking today about this bridge building. We really want to really get into some bridge building work. So we'll move forward in the next slide, Ayana. And so we have a couple of big goals today. And today's conversation, it will be the groundwork for the next 3 sessions. And again, we do want you to use the chat. I want you to use the chat, add questions. If you hear something that sticks out to you, put it in the chat. Let's discuss it. Let's really have a robust conversation. But our goals for today is I want to speak to 2 communities. I'm going to be talking to both the county behavioral health department workers and those that are in that field, but also to all of you that are faith leaders that are joining us here. So it's going to be a 2-way type of conversation going on, but it's really about building this bridge between the two communities. And so a couple of our objectives for today, or our goals for today, our objectives are, number 1, to cross-share. We want to cross-share our resources from faith communities and behavioral health crises resources from the counties. Number 2 is discuss the intersection. What does it look like? What is the intersection of a pandemic or a storm or a fire? What's the intersection look like for faith communities and behavioral health crises workers here locally? Look like for us in real time. So we're going to do a little activity and a breakout where you all will talk with each other. And then finally, consider opportunities where we can increase this work, increase developing new collaborations, as well as creating and thinking about how to create new collaborations going into the future. And so those are our objectives for this morning. So let's get into our conversation. We can move forward. Yes. So here's the first thing that I want to share. And this is really aimed at our crisis care workers, but also to some of you faith leaders who may not recognize this, that we are embedded assets. Faith communities, I want to encourage those that do the work as care workers in the behavioral health care field to understand, if you have not heard this before, if you're not aware of it, but also faith leaders, that you are embedded assets. So I want you to see yourselves as more than just pastors or faith leaders, but as an asset to the community. And we're going to talk about why, as well as for those of you that do work in this field, why we're even having this conversation is to really embrace and enlarge the understanding that faith communities are embedded assets in three kind of big buckets that we look at. Number one, as first responders. Number two, as communication mediators. And number three, as delivery or contact sites. So when we talk about first responders, we're talking about when a person is going through something like a crisis like a pandemic or a fire or something local here in the city, in our city or communities, typically they will go to someone within that community who is a faith leader or a spiritual leader of some kind. Now, this can be someone who is ordained and officially into this work as a faith leader, but it also could be the person in the community that everybody knows is a prayer warrior. So when we say faith leader, we're not just talking about those who are ordained pastors and clergy or rabbis or imams who have official titles, but these persons can also be the mother in the community. And you all are familiar with mothers in the community who are known as prayer warriors, or fathers in the community who have that kind of big brother, grandfather, strong spiritual connection. And typically when people are going through a crisis immediately, they tend to go to those individuals, whether they are the pastor, the imam, the rabbi, the Buddhist priest, or even the person in the neighborhood that everybody knows is a strong prayer warrior, and they can pray you through your greatest struggle, right? So asset number one, as first responders. Asset number two, communication mediators. Oftentimes, it is the pastor or the imam or the rabbi or someone in the faith community that will bring information to the community from either government or community or big agencies that are trying to get messages into the community. A perfect example of that is during this COVID-19 pandemic. A lot of pastors were approached and part of the network of funneling information to our communities about vaccines, about testing, about information. I myself, along with some other clergy, we even hosted information activities that inform communities that we worship, work, and live in about how they can access their resources for vaccines, for testing, but also to get a better understanding of what was really happening with this COVID-19 situation, this pandemic. And then delivery and contact sites. So that's asset number two. Asset number three is delivery and contact sites. It is oftentimes the place of worship, the place of prayer, the place where people gather, where a lot of services are, services as well as resources are delivered or become a contact site. Clearly in this pandemic, a number of congregations became the site where people could get testing, where people could get vaccines, where people could gather for food, could get clothing. During that pandemic, we saw things being shut down where people could not go to certain departments to get resources or their services. So services were brought in. A number of faith and worship houses were used as contact sites and delivery sites. And so this is the way we want to encourage everyone to see the faith community as embedded asset. And this is important because we have embedded assets where you have houses of worship, congregational spaces, churches, synagogues, and you name it, the breadth of what our worship houses look like, correct? That are within the community. And here, let me say this, even if people do not attend that particular worship space or that house, if there's a service being provided or information being provided, they know they can go there to get what they need. As a pastor in Los Angeles, we serve a number of people within the community who are not necessarily members of our congregation, but we're embedded in that community. Currently, we're embedded in Hawthorne. And so we serve members, not necessarily church members, but people in that immediate community in that area where our site is embedded. So that's why we call faith communities as embedded assets. So I want to encourage you all to see yourselves, those who are pastors and leaders, faith leaders of every kind, see yourself as an embedded asset, but also to those of you that do the work, behavioral health crises workers, also understand faith communities are an embedded asset. Let's move forward. In addition to that, this is how this could look in real time. This is a picture, excuse me. This is a picture of our church. We were part of, excuse me, a part of the Live Free Sabbath campaign. One second. That was something in my throat. Okay, don't want to talk about that. Okay, thank you. Sorry about that. So this is how this looks in real time for embedded assets. Food pantries, clothing drives, short-term, maybe even seasonal shelter, resources where mini grants, gift cards, grocery cards can be handed out, counseling sites where people can come and get advice and direction. The most important thing that we see a lot happening is our congregations are sites for grief and loss, where people are dealing with grief and loss. And so where you have vigils being held, gatherings for people to process their grief of their loss. And we saw a lot of this happening during the pandemic. A number of churches held, a number of congregations held vigils and just mourning opportunities for people to gather together and mourn. We see information and dissemination and sharing where people can come. And we know during the pandemic, people could not necessarily attend their congregations, but we had this wonderful thing called Zoom where we could disseminate information and share information. In addition, vaccine testing and even intake sites, a number of houses of are places where people could do intake for services that relate to either those who are experiencing homelessness or need jobs, et cetera, et cetera. And then they become certainly places for training centers because people can't always travel to corporate offices or training sites or things like that. So the embedded asset, the house of worship, becomes that place for all of these things to take place. And again, that's a picture of our church where we were part of the Live Free campaign, the Sabbath, and our site became a place for some of these things to take place. Let's go forward. In addition to that, we want to talk about how these houses of worship and faith-based communities, there's kind of like these two levels of ways to connect with faith communities. And again, this is for those of you that are doing work in the behavioral health science field, behavioral health care field, how you can look at connecting with the faith community. You have the houses of worship, right? You have your church, your synagogue, your masjid, your prayer centers. And then you have leadership roles, the pastor, the auxiliary leader, the praise and worship leader. You have all of these roles within congregational spaces or within houses of worship. And so that's one area of focus as a behavioral health care worker that you can connect with the community directly through the church, directly through the synagogue, directly with the imam or the pastor or the priest, et cetera, et cetera. And typically that organization, that faith institution will have congregational and membership focus, right? But then you also have faith-based community centers where they're connected to a church, but they serve the community. And this is important to understand because sometimes, even as a pastor, I can share this. We'll have people come to me, and I've had people come to me and say, well, we want to get something out of the community. And while I do serve the community, a lot of my focus tends to be with my congregation, my members. So what we want to encourage with those of you that work with the behavioral health care workers is to see both opportunities and both assets and to understand typically when you're talking with the house of worship, you're going to work closely with the congregation and the members. But if you want to increase and broaden your reach, we want to also encourage you to consider the faith-based CDC, many of which are connected to a congregation, but they operate and function maybe outside the congregation. So perfect example of that is Fame Renaissance. During my time at Fame, we had Fame the church, and then there was Fame Renaissance. And Fame Renaissance did loads of things for the community, everything from transportation vouchers to water programs, housing, et cetera, et cetera. And so Oftentimes, pastors and leaders of houses of worship are called on, but we want to encourage everyone to see that there are two kinds of levels of reaching the faith community and working with the faith community as an embedded asset into our community. Because you have the house of worship focus and then the faith base, and how they both have a different kind of reach. Of course, that crosses all the time, but just to kind of understand how that's broken up. And we want to encourage those of you that are working in the behavioral health care field to also look at, when you look at a congregation, ask the question, does this congregation, does this masjid, does this prayer center, et cetera, do they have a CDC connected to them or a CDC that they work with? And also be aware that there are a number of CDCs, faith-based organizations, that also may not be attached to a congregation, but they work with congregations. A perfect example is COPE, C-O-P-E, Congregations Organized for Prophetic Engagement. The COPE is not necessarily attached to a church, but they are a collaboration of churches. And so this is where we want to encourage those that do the behavioral health care work, is to do a little bit of maybe research, if you will, and ask the deeper question. We know there's a house of worship, but what about the faith-based CDC? Are you connected? Are you working with? Are there other faith-based organizations outside of the house of worship that we should be working with to reach the community at large? Okay, so we just want to see the two assets broken up. And yes, a CDC is Community Development Corporation. Thank you for that, Heliana. Community Development Corporation, if you're not familiar. And the next slide, please, Ayana. Thank you. Wonderful. So now we're going to look at things the opposite. We looked at the faith community as embedded asset. Now we want to look at our behavioral health care crises agencies as external assets. And here's how we kind of put those in three buckets. First, again, as first responders, but also agencies that offer a number of resources that faith communities can take advantage of. And then also, as an external asset, they are key agents for accurate information and mass communication. A lot of what we needed to know and understand throughout this COVID pandemic came from these behavioral health care agencies, these external assets. And what we mean by external assets is that they even though they serve the community, they may not be embedded in the community. So they're external, they're outside the immediate local community to your particular house of worship or the community in which you worship, work, and live. So they are a part of, and they may serve, but they're not embedded. So that's how we call them external, okay? And so again, these individuals and agencies represent first responders. They are the healthcare workers. They are the crisis counselors. They are the individuals that we also call on in times of crisis and emergencies, like the pandemic, like the fires, and earthquakes and things that we experience here in Southern California and abroad. They also offer a number of resources, information that as faith leaders, we may not have and have accessible to us right away. They have those resources that they make readily available. And a lot of times what has to, and part of why we're doing this conversation is so that we can build the bridge. And we're going to look at a graphic of a bridge so that we're not just, as faith leaders, people that work in the community, we're not just drawing information from the internet. We saw that happen a lot in this last year, Facebook, Instagram, et cetera, funneling a lot of bad information. And I'm not here to argue what side of the spectrum to be on, but I'm just saying that the internet and the way in which it is pumped with so much stuff, we may not always get the right information, but these external resources offer us the resources we need and the information we need in times of crises. And when we talk about resources, we're not just talking about information. This is resources that can be given and shared to our members and to our communities. So they can be anything from food to clothing to financial resources, things that people need in the time of a crisis, in addition to the vaccines, in addition to, immediate care for those who are not doing so well and struggling and going through it, but also the needs that our community members might need in that moment. Okay, so there are external assets. Let's keep going. So how does this look in real time? So we have a graphic there of several organ health, behavioral health care agencies that you can look up and look at. But we also want to talk about them being service providers for mental health, doing intake and testing. So now let's see the picture. You're a faith leader. You have a congregational site or a house of worship, a site where you can actually partner and collaborate with one of these agencies that can do an intake or testing at your site. This is the bridge we're talking about building. This is the collaboration. We also know that CARE has an asset map. And I want to encourage everyone, and possibly, Ayana, maybe we can put that link in the chat for those that are participating to copy and save in your notes, or copy and save and send to yourself an email. But this is the CARE asset map. And this asset map, if you click the link, will take you to a visual of what assets exist as it relates to Christ, the agencies, the service providers and agencies that we need in times of a crisis. So this asset map tells you where they're located, how to reach them. And a lot of times in the moment of a crisis, the moment of a traumatic experience, or a moment of a pandemic, we're trying to figure things out. You may not have time to research. You may not have time to call someone. So this asset map tells you what's in your immediate area where you can direct either members of your congregation or even those from the community to go to when they need to go to additional resources. They also provide shelter resources and counselors. And so this is a way, this is how these behavioral health care agencies look like in real time. Let's go forward. So here's what we want to do. We're going to take a little 5-minute breakout, and you're going to share additional assets. Because again, our list was not exhaustive. There may be some additional assets that your organization provides. So we're going to do that breakout for about 5 minutes. All right. Welcome back, everyone. Welcome back. Welcome back. Thank you for participating in the breakout. Let's hear from two people, maybe a faith leader and someone who works in the behavioral health care field. What you talked about in your breakout group, just real quick, two people.
Okay, my name is Gloria Davis. I've been an ordained minister for 20 years, but in ministry for about 30 years. And I'm part of a deliverance ministry called Confirmed Ground Ministries in Pasadena. And we collaborate with a group in Pasadena of pastors and education components, the Board of Education, the police, and other leaders that want to help do work in the community. We meet once a month, and so things that each congregation or each individual nonprofit organization, if they need resources and what have you, it's about 60 of us.
Nice.
We come together and discuss those issues, and for the ones that have the information concerning the resources, we share that. And I was also sharing that our congregation works with the Pasadena Police Department because of the various shootings that we've had in Pasadena.
Okay.
We also have a couple of social workers that are part of our congregation. So, and that's a plus. So we utilize them not only within our own congregation, but also in the communities. And they can help those families that have experienced grief during the death of their family members that were killed by the Pasadena police.
Thank you, Gloria. Thank you for sharing.
Mm-hmm.
And if we have someone from the behavioral health field, someone who works in that field, I know that we had someone in our group, Austin. Do you want to share, Austin, about your asset?
Oh, yeah. So basically, I said that as a faith leader, one of the ways in which I can better equip my own faith group is training them to be first responders, right? As you said, in order to respond to things like mental health or like, physical health crises. Yeah, so I think that providing that type of training, either on your own or through an external organization, would be a really good asset.
Wonderful, thank you. And Austin represents kind of like the younger generation of individuals working in this field. So thank you, Austin, as well for sharing. So let's get back to the latter portion, just a couple more slides, and then we'll have some Q&A, and then we'll have a Mentimeter, and then we'll close out for this morning. So if we can bring our slides back up, our PowerPoint back up. So two big ideas that we want to just talk about real quick as we were talking about building this bridge. And the first is that looking at the intersectionality of an emergency. So a couple of questions we want to encourage everyone to ask when we're experiencing a crisis, like the pandemic, like a fire, like an earthquake. And when we talk about this intersectionality is what is happening, but also what else is happening. Like we know there was a pandemic, but there's all these other external factors going on at the same time. Who is most impacted and most vulnerable in this moment, in this space, at this intersection of an emergency and local community? Who's most impacted, who's most vulnerable? And then how do we respond? And that we being faith leader, faith community, and healthcare, behavioral healthcare agency and or worker. And then what's the needs being assessed, or how are needs being assessed? And what is needed and how do we respond in that moment? The other set of questions for our faith and crisis care bridge building is in order to respond to the emergency, right? Then you have the other space, which is the faith and crisis care bridge, workers, individuals coming together. And here's a few questions that we want to encourage you to ask as well is, who are the available assets? Who are the available assets as it relates to crisis care workers, but also who are the available assets as it relates to faith communities? Who's available, who's embedded, and also who's external? What is needed, right? This is a capacity issue. What's needed, but also what can we provide? How do we collaborate? Faith community and crisis care agency. How do we deliver what's needed at the intersection? How do we improve crisis care to the most vulnerable in our communities? How can we improve it? Because we have to constantly, sometimes, especially in the midst of a crisis, an emergency, we move the way we move, but over time we figure out how to do it better. And and we've seen that even with the pandemic, information was disseminated. People, we were told what we were told, but over time, we've improved the process, we've improved the dissemination of information, we've improved our understanding how we're navigating this pandemic together. So let's look at a graphic that kind of puts all of this in a visual format for us. So you have this intersectionality, right? You have the straight line, which is your faith community and your behavioral health crises agencies and workers. And then you have your emergency. And so a couple of crises that we are all very familiar with, of course, the pandemic, COVID-19. We've seen an uptick in violence here in Los Angeles and abroad. Earthquakes, of course, can be a huge natural disaster, as well as our fires. And so what I want to encourage you all with, at this crises intersectionality is to, with those questions that we ask, begin to ask those questions of yourself, of your organization, of your faith community, so that we can respond at the intersection of an emergency or crises, but also as a faith leader or a behavioral healthcare worker, how do we work together to meet the moment or meet the intersection? How do we work together, making one line, to meet the moment or the intersection? Okay, so that, again, that's what this whole conversation is about, is collaborating, working together to meet the moment. so that those who are most impacted, those who are most vulnerable, those who have the most to lose are getting what they need. This is how we build communities stronger. This is how we respond to social injustice. This is how we heal even through something like a pandemic. Okay, if we can go to the next slide, please. Okay, so today was all about bridge building. Bridge building between our behavioral health departments and our faith communities. And here's our big goal overall, what we hope to see improve in these next 4 sessions. And it's also why you're going to have homework between now and the next session, because we want to improve access. Social injustice is not just the things that happen. It's also when what's needed for people are not available. Access or not having access to what's needed is a social justice issue. So we want to improve access. We also want to improve equity, that people are getting met with their needs where they are, right? Where they are. And by collaborating together, we can help faith leader as well as behavioral health departments, agencies, and workers. We can help make sure that people are being met in the moment where they are. Not where we want them to be, not where we think they should be, but where they are. Because in a crisis is not the time to determine why is a person where they are. That's not the time for that. The time is to meet them where they are so that they can get what they need, so that they too can heal and improve and get a better opportunity during a crisis. We want to improve delivery. One of the things we saw years ago with Katrina was this big debacle in delivering what was needed to people who were trapped, literally trapped in parts of New Orleans and in and around that area. So we want to improve delivery. We certainly want to improve service. People deserve the dignity of getting the best quality service during a time of crisis. And again, when we build this bridge, behavioral health departments and faith communities, we can deliver a great service to make our community stronger and better. And then we also want to improve wellness. Listen, it's not good enough for just one side of the bridge to be okay and the other side of the bridge not. When we build the bridge, it's about wellness for everybody, no matter what side of the bridge you're on. And so when we work together, when we partner, we collaborate and build this bridge, it's about so everyone can receive adequate care and wellness, especially during times of things like a pandemic, these large fires we've experienced, earthquakes, violence, et cetera, whether it's a natural disaster or something that is man-made. By building this bridge together, we can improve wellness for all. And so as we close out today, we can go to the next slide. As we close out today, we want to offer a few moments to those of you that may have questions or comments. We have about 15 minutes left for discussion. So let's do a quick Q&A, and then we're going to have everyone participate in a Mentimeter, and then we'll close out. So any pressing questions and or comments? Feel free to unmute yourself. Any questions or comments or thoughts?
This is Chaplain Ruth Bolansky. Good morning.
Hi, Ruth. Good morning, Ruth. Yes.
So my comments really are that until the issue of social justice and the focus on mental health as an important aspect, one of the most important aspects of social justice,
Yes.
Until it's viewed in the same way that cancer is viewed, or that diabetes is viewed, or that any other illness, physical illness is viewed, and the same amount of money is distributed towards that, we will never have equity.
Yes.
And unfortunately, it only comes to the fore when there are people of social importance or sports importance or political importance. Mm-hmm. Otherwise, the average person is not heard and is not seen.
Yeah.
How to make that happen? I don't have all the answers. I think that's the discussion that we actually need to have, which is how do we promote it, and how do we promote also reducing stigma.
Right. And thank you for that, Ruth. And I would offer, and again, like you, I don't have all the answers either, because I think we are up against so much stigma and so much taboo to this discussion that what I see is that we are just now getting to a place where we're willing to even normalize the conversation, but it hasn't been normalized. And I do believe that this type of learning collaboration and continue pushing it out and continue to have both sides of the bridge come together and really work together and really amplify this message. This is how we term the title of that. I think for far too long, we've kind of worked in our silos. And part of why we've brought this learning collaboration together is that we're not working in our silos, but working more and more together and building not just a bridge, but a stronger bridge, a wider bridge, and a bridge that extends out, and the bridge that's replicated in other areas. So I think it's just a continued process. I like where I see things going as it relates to behavioral health and faith communities coming together. And like I know, the faith community is very guilty of making mental health a very taboo conversation, a very spooky conversation, and one that even suggests that if a person is looking to deal with their mental health in a clinical way, somehow their faith is not strong. And so this is why we have to work together and build that bridge. And certainly, thank you for your comment. And that's something that we can add as we continue this conversation with these other collaboration sessions, is really talk about stigma and how to overcome stigma on both ends. Mm-hmm.
And the thought, just occurs to me also, is that we have Alcoholics Anonymous, we have Al-Anon, we have all these organizations. What we really also need is to have maybe a day or a day a month that we encourage faith organizations to encourage family members to come forward and say, this is what I am, or this, I have a family member, and this is what it does. This is the pain that it causes. This is the pain it causes to the person who suffers, and this is the pain that it causes to the family. And to bring it and put it out there, because I have found from my personal experience that the more I talk about my family member who has mental illness, the more I talk about it, the more it offers other people an opportunity to talk about it. And that's the only way that we can crack the stigma.
Yeah, absolutely. Got to bring it front and center. And so thank you for that, Ruth. And that's what we're hoping to accomplish with these 4 sessions, is to bring the conversation front and center on both ends and build this collaboration so we can work together to amplify the very message that you're saying. We've got to bring it front and center. And there is no way around that. So thank you. Definitely agree. Any other comments? Because our time is wrapping up, so we're going to make sure that we do our Mentimeter and then turn it back over to Heliana to close us out.
Good morning, Pastor Najuma. This is Joanne Russell with Let's Make It Happen.
Yes,
and what you were just speaking on, I must say that there are inroads being made, because my team and I last night participated in a training on CRM that was hosted by a local church, so that we could start having the conversation. And I like how they did it, because, it was for a mixed audience, but it was like, if you had issues, they helped you understand, and it helped my team be able to understand how to help people through those unquiet moments and things like that, to lead them to the assistance that they needed. So yes, they are starting, and that's what we work on, helping the information get out there. But yes, it is starting to happen. It's starting to happen on the ground level where we need it.
And you know what? Speaking of that, Joanne, inroads are definitely being made. That's part of why we have this today's session and other 3 more coming up. But here's what I want to encourage each of you to do, especially those of you that are faith leaders. And not just everyone. Do one, especially if you're on social media or if you have an email list, and share this conversation and invite others from your networks to join us in the next one. Here's why. People tend to do things that they know other people are about. And the more we encourage others, and not just those that you know would typically be in this conversation, but even those that have shied away from it or who haven't engaged this conversation around mental health, behavioral health. So that's faith leaders, but also workers. Take time today and share what you are a part of, and then invite them to join us again in January. Because what we want to do is we want to improve this conversation. We want to expand it. And that's why we're starting here today. So thank you for that, Joanne. Let's go ahead and do our Mentimeter. And if you have any other thoughts, we certainly want to encourage you to put them in the chat. But we want to do our Mentimeter. And certainly the Mentimeter is simply, I used to think and now I think. And so just one thing that you picked up today, and again, today was about kind of grounding our conversation for building this collaboration between behavioral health care and faith communities. Yep, and you can type in the chat if you need to. And again, thank you everyone for joining us today. We're so grateful to your participation. Please invite others to join us. I used to think that our ministry was limited because of my perspective, our demographic size and traditions that tend to keep us behind. Okay, but now I guess wonderful. Thank you for that. Excellent. And so when and this is a great point that you make, because when we collaborate with the behavioral health agencies, our capacity is increased. So even if our ministries are only able to do X, Y, and Z, the partnering and collaborating with the behavioral health agencies allows us to do A, B, and C, 1, 2, and 3. And so, so this is why building these bridges and collaborations are important. I used to think that communities affected by behavioral health community crises must be helped by tracing back the root causes of the crises. Okay, wonderful. Thank you for that input. Yeah, I'm not sure if we can always trace them back. I mean, I guess in opportunities where we can, that can be important depending on the scenario. But also seeing where people are and starting there is important as well. So thank you for that input.
I love that last point that you just made, Reverend Smith-Pollard, that idea of what is in front of us. And we'll be rolling out some crisis care, first response kinds of trainings. And what is coming through, whether it's psychological first aid or what have you, is that we attend to the basic needs in that moment. When we can help somebody have food, when we can help them to meditate or to pray or to slow down the central nervous system, then we can get them to a more recovered moment so they can have that problem-solving capacity come up. And so exactly what you were just saying, oftentimes in the moment of a crisis, it's about what's immediately in front of us rather than those root causes.
Yeah, absolutely. Thank you for that. Absolutely. The bridge would and should be built by the experts. Yes. And so I used to think the bridge shouldn't be built by experts. Yes. And here's the thing about the word expert, because oftentimes those of us who are embedded assets, we're experts as well. And so this is why we call faith communities embedded assets, because we are assets, you are assets, experts as well. And to Heliana's point, you being able to bring a person down to a place of presence through prayer, meditation, makes you an expert. And so that's important to understand. Now I used to think we were not assets. Now I know that we are assets. Wonderful. Now I think our collective path for reaching people who need mental health service and will become normalized, acceptable as more people engage. Absolutely. So continue to put your response in the chat or into the Menti that through collaborative efforts, we can expand our conversations. Yes, 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 and yes. That is the point. Expand our conversation, expand our efforts, and expand our reach. The asset map link. Ayana, can you put the asset map link into the chat one more time for us? That's being requested. Thank you so very much. So you can continue to put that in. I'm able to contribute in a valuable way to rebuilding the bridge, ability, responsibility. Absolutely. Bridgeability, responsibility. I love it. Perfect. This is exactly what we're going. So we're going to go back, just kind of close out our presentation, and then I'll turn it back over to Eliana as we close out. But again, thank you everyone for your time. Please, please, please invite someone to join us in January. And so we have a little bit of homework assignment. So we do have some upcoming sessions. So we'll just kind of put those up again for us.
Before we go to that, I wonder if I might take just a moment to show them the asset map, since it sounds like there's some interest in it, if that's okay.
Sure, absolutely.
Awesome. All right. I'm going to actually go ahead and show you the link. So if you were to go to the CARE TA Center website and you come up here to Resource Library, it's the bottom California County Crisis Continuum Asset Map. And once you come into the asset map, you can search it by either placing your cursor over the map, or you can search it. Oh, it's going to think it here. On the side panel, you can also search by the particular county in a drop-down menu. So you could say, let's just pull up Calaveras County, for example, and you can search what kind of resource you're looking for. If you're looking for a crisis resource, if you're looking for justice diversion, or maybe some combination thereof. So once you select your county, then what comes up down here on the very bottom are those services that are available to you. So for an example, here we go. Here's a service that is for adult and transition age youth triage program. So this is a behavioral health team who provide emergency services. And if you were to scroll over to the right here, you would see a contact information to connect your community member to this service. If, let's say, you're working with somebody who is calling in concerned about a family member who's in another county, this is another great way to figure out what resources might be involved in the community that's just adjacent to you or somewhere else. So again, you can click on the map itself, like I've just done here. I've pulled up San Bernardino, and you can just skim through. Because maybe if you're like me, I don't know exactly all of the counties that are here, but I can visually pull them up in that direction. So again, these are county programs that are through the Mental Health Services Act funding. If you're part of a county behavioral health department and you were to go look up your program or your county and there is a program that's not listed here, please feel free to complete a short form by selecting this link, and we will consider putting it in here. Everything that we do is funded through the Department of Healthcare Services. So when we update this map, we run everything through them. So it won't be an immediate presentation of your program into the county map, but eventually it'll go through our review process. So thank you, Ayana, for having put that link in the chat box. And we are in the process of putting together a survey for faith communities and lay ministers and other leaders in faith communities, because we know that you have so many crisis care services and emergency response services within your community that are not necessarily funded through MHSA, so they wouldn't have shown up on our map. But we'd really like to share those resources across the communities as well. So with that, would you please pull up the slides for us? Want to say a huge warm thank you to Reverend Smith Pollard. We are so fortunate that you are here with us today. This is exactly the kind of conversation that we were excited to start up. We are so grateful to all of you who are here as participants in this conversation as well. It is incredibly powerful to know that together we can be healing through a pandemic, as Reverend Smith Pollard mentioned earlier. And so we've got here our flyer for the continuation of the next 3 sessions, which we had talked about. As I mentioned in the beginning, we provide no-cost training and technical assistance to the community. So maybe you're a faith leader who said, oh, Ramirez mentioned that thing about psychological first aid. That is a very specific evidence-based practice for anybody. You don't have to be a mental health provider to learn how to help somebody in that crisis moment do what we call down regulate. That is slowing down the central nervous system so that they have the capacity to do problem solving on their own. If you would like to learn about resources like this, or if you'd like somebody to come in and help your team, for example, think about connecting with other local crisis response or something else along these lines, please do feel free to go to our website and submit a TA request form. Oftentimes this is for, and thank you, Ayana, for putting this into the chat box as well. It might be that you're requesting a training, someone to come in and train your community, or maybe you'd like to have access to some resources that are in our resource library, what have you. Finally, please do stay in touch with us. We would love to receive your feedback, requests for TA. And you can see that we've got several ways you can connect through social media, through email, good old telephone as well. Without further ado, I just want to extend a huge thank you to Reverend Dr. Najuma Smith-Pollard. This was an exceptional first session today, and we are so excited to meet with you again in just a few weeks here. The final thing that I will share with people is that in our follow-up email, we are going to send that homework sheet. And the homework sheet is encouraging you to think about, one, who are some of the local community faith leaders, lay ministers, and or behavioral health crisis care providers that you don't currently have a connection with. How might you get connected with them? And how might you start to share resources? You might, if you're a behavioral health provider, realize there is a faith community right there down the block. Might reach out to them. Introduce yourselves and find out, do they have a newsletter that they send to their community? If so, perhaps they would be willing to share about a behavioral health resource that you provide in that faith community newsletter, or vice versa. Or maybe the local behavioral health county department is going to have an event. That might be a great opportunity for the faith community to come and share some of their information about the emergency response resources that are provided following crises in the community. So how can we start to identify those local assets, both internal and external assets, and start up those conversations? We invite you to go ahead and complete that form in preparation for our second meeting, which is coming up in just a few weeks. Without further ado, we are here at the end of our time together. Thank you, Reverend Dr. Najuma Smith-Pollard. I invite you to say any final comments here.
Yes, and I just want to say today is a perfect example of the bridge building we're talking about. Myself as a pastor, but care, TA, being in this behavioral health, field, this is the example. Like what we're doing, this learning collaborative is the example of the work that we're talking about that we want to encourage all of you to do within your organizations and within your communities. And so, prayerfully today was a great example of that for you. And so you can now take it back to your local organization, house of worship, and let's expand this work out so we can really meet the needs and bring this conversation around mental health front and center for all of our communities. Thank you so very much.
Thank you for everyone who's here. Thank you to Ayana, Ruth, Ande, Stephen, everyone on the care team who made this event possible. And we will look forward to being in community with you again at our next Learning Collaborative. Thank you all so much. Have a wonderful day.